Right. I'm very honored to introduce Dr. Ryan McNeil, he, him. Dr. McNeil is an associate professor of internal medicine and the director of harm reduction research at the Yale School of Medicine. Through his National Institutes of Health-funded, community-engaged, qualitative and ethnographic research, he examines how forces operating within the risk environments of people who use drugs shape risk and harm. His foundational research on harm reduction approaches, including supervised consumption services and safe supply, have been instrumental to informing their scale-up. Dr. McNeil regularly provides expert advice to healthcare organizations and governments on the development, implementation, and optimization of harm reduction and addiction treatment interventions. Pursuant to the goal of meaningfully involving people who use drugs in all stages of the research process, he actively collaborates with community-based organizations, including peer-driven drug user, sex worker, and tenants' rights organizations, to align his research with community priorities and provide opportunities for people with lived experience to co-lead and engage in research. Furthermore, Dr. McNeil is the co-creator and scientific lead of Crackdown, a podcast launched in January 2019 to mobilize research and amplify the voices of people who use drugs. This innovative media collaboration has been called the podcast most likely to save lives and has received the Radio Impact Award from the Third Coast International Audio Festival, Canadian Hillman Prize, and a silver medal from the New York Festival's Radio Awards. We're very grateful to have you here. And with that, here's Dr. McNeil's presentation. Thank you so much for being part of this.
Morning. Thank you so much for having me. I am going to share some slides, which, frankly, for those following along, are really easy to follow without being able to see them, should one not be able to be engaged with them. They're mostly text, which is great. Please pop questions into the chat as I'm going along. I'm happy to try to answer them as I go, if possible, and without disrupting the flow of what I'm saying. But I also recognize some of the wonderful names of folks in the attendee list. And the great thing about this is so many people who might be joining are probably almost better equipped to be able to answer questions than I am. And so with that, I will begin. So I'll be talking about responding to the needs of people who use drugs, specifically focusing on structurally vulnerable folks who use drugs, and how we can think about providing culturally safe care and harm reduction support. I'd like to begin with, the experiences of a participant in a study of mine that I always come back to when I'm thinking about care and how we fail structurally vulnerable people who use drugs. Mary, pseudonym, was a 29-year-old Indigenous woman whom I was meeting with one day in the downtown east side in Vancouver, Canada. She'd been a long time, at that time, there still was, heroin user, who had really had her life shaped by the traumas of ongoing colonialism in Canada, racialized violence and gendered violence occurring within the downtown east side, and suddenly found herself sick, and quite sick. And she described it like this: my head was pounding, couldn't stand the light, I was freezing, and then I was hot, and my nose wouldn't stop bleeding. The nurses at Vancouver supervised injection site, Insight, called an ambulance so that Mary could be taken to hospital after a doctor showed up at the site to check her out. And she went to the hospital and she explained, I went to the hospital, they gave me ibuprofen and sent me home. I went to the hospital 3 times showing up at emergency departments in the city. They told me nothing was wrong. On one of these visits, Mary learned that she was pregnant. The doctor looked at her and told her that there was nothing wrong with her. She explained, they said I just had a fever and to just go home. And I was in excruciating pain. And I told them that if they didn't give me any kind of pain control, I'd cut this baby out of me. So they gave me Dilaudids or whatever and sent me on my way. And the pain was, and of course, I didn't take them by mouth. I fixed them, injected them. And then another week went by. Still, Mary's not getting any better. She's not improving. She's still sick. She's still dealing with nosebleeds. And so she went back to the doctor again. They told her that nothing was wrong. They basically said she was just another, quote unquote, and excuse me, junkie addict looking for free drugs. They had security escort me out, and I just didn't bother to go back. And now eventually things hit the point where Mary did have to be brought back to hospital by ambulance and did have to be admitted, because it turns out that whole time Mary had meningitis. And yet her care was framed by the structural violence imparted on people who use drugs by prohibitionist policies that become routinized through the everyday violence of poor care and discrimination that folks who use drugs experience in hospital and other care settings. And really thinking back to Mary's experience, this is one of the primary things that'll effectively animate my talk today, which is really how we can do two things. So first, think about how medical settings or healthcare settings operates as sites of social violence for people who use drugs. And then how we can think through what role harm reduction approaches can play in reshaping dynamics in hospital or other medical settings to improve care. And in doing so, I'll be drawing primarily on work by my team, which has effectively involved longstanding qualitative and ethnographic research in Vancouver, Canada, as well as drawing on the larger literature. And through this work, we've been concerned with risk, harm, and healthcare access among structurally vulnerable people who use drugs. And this has included studies that have looked at people's experiences in hospital settings, why people have left hospital before completing treatment, experiences with an array of addiction treatment programs, from residential recovery programs to medication for opioid use disorder, to even some of the more advanced options available in Canada that should be available here, like prescription heroin and other injectable or oral opioids that are critical to addressing the overdose crisis. And I will draw also on work that's considered how harm reduction services or approaches can be mobilized in these settings to enhance care for people. And so over time, this work has effectively involved interviews with hundreds upon hundreds of people who use drugs, as well as hundreds of hours of ethnographic observation across a range of settings, from street-based settings to clinics to harm reduction services, through which we've been really humbled and honored to be engaged with folks who use drugs. Our wider team of folks working on this work, which includes people with lived or living experience of drug use, to be engaged around these issues of, first, what's happening and what we can do. Through this work, we've been explicitly focused on social structural dynamics that underlie care for people who use drugs. That is, how we can think through things like policies, norms within care settings, prescribing policies, drug prohibition, are critical factors that effectively frame out what is possible for care and the wildly discriminating care that the people who use drugs experience on a regular basis as they engage with these systems that they commonly characterize as carceral, or quote unquote, as like prison. And so effectively in thinking about this, there's really two, I think, key points to bear in mind before jumping into some really key takeaway messages that we need to consider to address the questions that I first raised. First is, why focus on the experiences of structurally vulnerable people who use drugs? Well, certainly, first and foremost, we know that people who are structurally vulnerable, so specific groups of people who are affected differently by structural arrangements in society and how they intersect with cultural norms, we know that there's differential outcomes across groups of people who use drugs. And, drug use as a category, or people who use drugs, is often a bit of a misnomer, because as something that captures a wide-ranging group, there's a significant difference between, a white upper income person who may use occasionally and someone whose experience is shaped by interlocking structural and social inequities, including structural racism, how that's embedded within everyday practice and experience, poverty, which can also include geographic stigmatization or territorial stigmatization, should a person be from a particular neighborhood or community, and all of these markers that produce widely differential outcomes that mean that some people have worse experiences than others. And the work that we've been doing has primarily been done with folks who would be characterized as incredibly structurally vulnerable on the basis of often entrenched poverty, racism, and particularly the representation of Indigenous folks in the work that we've been doing very specifically, are affected by drug prohibition and ongoing engagements with police and other carceral systems, bring with them histories of engagement with broader settler colonial systems, often and very specifically the child welfare system. And so if we understand that these arrangements produce vulnerability, we need to recognize that an important place to start in improving care is with those who are most impacted and those who often have the worst outcomes because of how they're treated by society. And in doing so, it's just important to think about how we can focus attention on the experiences of structurally vulnerable folks, and a particularly helpful frame that we've been developing and building on is the intersectional risk environment framework or approach, which builds off the original risk environment framework popular in drug use research and other fields to focus attention on how social and structural arrangements that include social norms, policy frameworks, which again can include things like prescribing practices, drug prohibition, et cetera, physical dynamics, so characteristics of settings, distributions of services, et cetera, and economic conditions. So how society is organized, labor opportunities for income support. How these are critical dynamics that work together in different ways to shape vulnerability. And certainly one thing we focused attention on is how, again, these are differentially experienced on the basis of interlocking factors that all work together to produce different outcomes among different folks who use drugs on the basis of things like age and gender and race and ability and citizenship status and sexuality and class. And so it's to really hold ourselves accountable in the work to, ensure there's not a flattening of experience of folks who use drugs that treats everybody the same, because these key differences are important, and they're especially important when we think about how to meaningfully respond to provide support and care to people in a way that's responsive to their needs and the diversity of their experience. And in that, it's helpful to think about harm reduction as a particular type of intervention that, we've termed a safer environment intervention that effectively works to intervene across these social structural contexts. Again, things like social context, policy context, economic context, physical context, to promote conditions, settings, or situations where drug use can be safer, or in turn, where we can produce safer outcomes. Because ultimately, and this is something I'll come back to, this is a key point. We arrange care in ways that are, quite frankly, horrible for people who use drugs, that themselves produce social suffering. And we need to intervene on these to produce conditions that allow for better care, for better engagement, for us to serve folks in ways that we should be, and to also build off the strengths of communities and the work that happens within drug user communities as well, to serve as a key point of support and care, pursuant the goal of better helping people survive the hardships of society and be well. And so some key points in this work. So first and foremost, I wish to foreground that care settings operate as complex sites of social violence that frame access to and engagement with care among structurally vulnerable people who use drugs. And so if we think back to Mary's experience, which I opened with, we see someone who has first very poor access to primary care for the purposes of engaging with care, and is accessing care through a harm reduction space, in this case, Insight in Vancouver, a medically supervised consumption site, really on an emergency basis. But is showing up at hospital and dealing with, and I wish to be clear, outright discrimination on the basis of intersecting factors that include her drug use status, her gender, and the casualization of women's pain and suffering. And finally, the view that as someone who uses drugs who's Indigenous, of quite frankly being treated as disposable by care systems. And so this site then operates this medical system as a place where she receives poor care. or receives no care in ways that leave her incredibly vulnerable to adverse outcomes, including death. And so here it's important for us to think through how forms of structural and everyday violence are embedded within care systems because of how they're arranged. So again, if we think back to Mary's experience, her experience as someone who used drugs accessing care is framed by anti-drug policies. The view, quite frankly, as she articulated in our engagements with one another, that she was viewed by these systems as quote unquote drug seeking. That she was there to quote unquote get high. And that was counter to the objectives, missions, policy directives of that healthcare setting. And as such, she could be denied care. That there's operating procedures within hospital that casualized her experience and led to this discrimination. That created contexts in which her care could be poor. And finally, cultural norms within these systems, the routinized poor treatment and discrimination against people who use drugs that is expressed through stereotypes, it's expressed through denial of quality care, it's expressed in interpersonal ways through people's engagements with these systems. And that these produce suffering and lead people who use drugs to avoid care. Again, in Mary's situation, not going to hospital, having to be brought by ambulance from Insight because of meningitis. And that in turn, once people are hospitalized, that these produce situations or settings that effectively push people to leave before their treatment is completed. That is, people are actively discriminated against, they're surveilled, they deal with suboptimal care in ways that often make people feel that it's safer to leave than it is to stay and be engaged with care. And so here's a quote from a participant in one of our studies that speaks to this routinized surveillance that people are subjected to in hospital settings that can function to push them out and create a hostile environment where it's clear that they're not welcome. Quote, I went to the bathroom and they sent the police in the bathroom. They said I was taking too long and I thought I was using drugs in there. I was on the toilet and the cop walks in with a key. He says, you're taking too long, get the fuck out. He's swearing at me. He's standing there with the security guards and a couple of staff from the hospital. They physically escorted me out. They told me they were going to arrest me if I stepped back on the property. They said I was creating a disturbance. I was just using the bathroom. And this is a sentiment that's commonly expressed and an experience that frequently happens among folks who use drugs, of being escorted out or kicked out of hospital on the basis of the assumption that they may be using on site or are otherwise quote unquote problematic and need be removed. Now, in this case, this particular man had been hit by a car and was showing up with severe traumatic injuries and later did have to return to hospital to get them to be addressed because effectively, what else are you going to do when you have broken bones? And yet dealt with a delay of care and lingering and ongoing outcomes from a significant delay in treatment. Now, one of the most common ways we see this expressed is in an inadequate pain and withdrawal management that are a form of everyday violence that normalize suffering and lead people to avoid care or leave hospital. Again, one of the most common experiences that folks who use drugs experience in care settings is the denial of their experience of chronic pain, but also withdrawal specifically as a key outcome or key dynamic that needs to be managed, addressed, and oriented to create a situation where someone can be well while engaged with care. And so it becomes a common concern that is framed as a barrier to ongoing engagement with care systems. And so in this work that we were doing with people who left hospital before completing treatment, it was commonly expressed that people would show up for severe injury, complex needs like injection-related infections, other things requiring extended hospital stays, and they would effectively suffer while hospitalized because their pain wasn't being managed, because of interruptions in their access to medications for opioid use disorder, because of challenges in engaging with the system and the assumption that in many ways it was routinized that they should suffer as part of care. And so one of our participants describing her experience in hospital, I had to get out of there while I could move because I was losing so much weight. When I begged and begged to get some help, in this case prescription opioids, they weren't going to do anything. And so I just said, fine, I'm leaving. I was concerned about the health consequences of leaving hospital. I got this other thing, opioid dependency, and it's like you're stuck between a rock and a hard spot. I mean, how can I even fight off the infection if I can't stop puking and shitting? And so this particular participant on this instance of leaving hospital before completing treatment was leaving with a severe injection-related infection that later led to a much longer hospital stay because of this interruption in care. And quite frankly, she was lucky not to have lost her leg as a result of the infection. And yet within this context, leaving was seen as something better to do than continuing to be in hospital and suffering because of lack of care responsive to her needs. And here's what just a key point to bring in mind is we see routinized suffering among folks who use drugs in hospital settings, but it too occurs across other care settings, where there's this expectation that pain, that withdrawal is something to be beat, something to get past, it's something to deal with as a consequence of drug use, and yet need be understood as natural rights of use. Now, as mentioned, in the case I shared earlier, these dynamics subject people to surveillance, both directly and indirectly, but most commonly for the purposes of enforcing anti-drug policy. But these are effectively counterproductive in terms of supporting one's health and wellness beyond how undignified they are, because they produce high-risk drug use. And so one of the things that we commonly see is that we need to understand that hospitals, other care settings, from treatment settings to hospital clinics to hospital settings to any place folks might be, are sites where drug use is happening. And one of the things that certainly commonly happens among folks who are hospitalized is drugs still make their way into the hospital, are critical in helping people manage withdrawal, cravings, and pain, particularly in the context of their routinized suffering. And yet they need to hide what they're doing in order to avoid being involuntarily discharged. And so they can still have access to what often is life-saving care. But this means that it pushes people into high-risk settings like bathrooms, like other places they can nip into in order to use without being detected. And especially within the context of a drug supply that could only ever be characterized as toxic, that's a life and death situation that effectively pushes people into the one thing we really don't want folks who are using an especially toxic drug supply to do, and that's to use alone. And so one of our participants put it like this. If you're sharing a room with somebody, there's always that threat that somebody's going to come in and not realize you're in there, the bathroom, and open the door. I think they pretty much have a zero tolerance. I was worried about getting kicked out and not getting the proper care that I needed to get better. I'd turn the tap, so if they came in my room to check to see if I was okay, then they'd hear the water running. So they'd figure she's just in the bathroom. And within the context of a supply that could at any moment kill somebody, this is an abiding concern that just shouldn't stand as a practice in hospital and other care settings, given the extreme risks at any moment. Now, two, this also pushes people to leave either on short passes or to try to nip out at hospital and come back in order to use, often using then in situations or with a supply that's incredibly unpredictable, amplifying risks and pushing people to end up disengaged with care. And interestingly, a growing body of research is effectively showing that the period immediately upon release from hospital is really one of the highest risk periods for fatal and non-fatal overdose. And certainly it is unsurprising given that we know that this pushes people into high-risk situations, and in turn can also occur when people have a shift in their tolerance or might not have a potentially be engaged with a protective medication for opioid use disorder. Now, as a final point in characterizing what we really need to think about of care settings as risk environments that produce harm, one of the things to also bear in mind is that approaches that are coercive and that often involve leveraging the trauma and vulnerability of people who use drugs can in turn undermine care relationships and have long-lasting impacts on willingness to access care. And so one of the ways that we'll see this, paradoxically, we've done work around context of initiation for medications for opioid use disorder. And while access to these through an emergency department or through a hospital can be critical, they need to be done with incredible care and a trauma-informed approach in order to ensure that the context of initiation themselves are critical. Because if not, they can be experienced as traumatic, as negative, and can lead to longer-term disruptions in the willingness to access medications for opioid use disorder. And so a participant in a study that we were doing is describing how he had been hospitalized for endocarditis. And that became a point when he initiated methadone, but it was very much not something he was interested in. So he put it like this. I had a heart infection, endocarditis, and I went into the hospital. They were giving me morphine for a while. The doctor for addicts, again, excuse me, came in and he prescribes the morphine and stuff like that. He kept me on morphine because of my heroin. I was wired to heroin. And then he asked me if I wanted to go on methadone. I heard methadone was crap, right? And I told him no. So here we have someone expressing that initiating methadone is not necessarily something that they're interested in, is attempting to carve out agency in this. But then he said that the physician said, okay, but you're here for 3 weeks. And in 1 week, your morphine's up. I really think you should go on it. I think it was 1 week before I was so sick that I was like, okay, I'll try it. And so in speaking with him about his overall experiences on methadone, what we effectively later uncovered is this was experienced as incredibly coercive and undermined the trust and faith that he had both in methadone as something that he should be on, in a healthcare system or addiction treatment system that didn't recognize that he was someone with agency who should have a voice in his care and what that looked like. And what that meant is he effectively cycled on and off methadone because it was not something he ever felt that he liked, that he wanted, or that was for him. And so that further fueled larger distrust in these systems because of the lack of faith that he had in them to actually listen to and care about what he wanted. Now, against this larger backdrop, it's important for us to consider that here and very explicitly changes to the social, structural, environmental context of care settings, specifically through the integration of harm reduction approaches, have incredible potential to increase cultural safety and care and improve outcomes. And so what we mean by cultural safety here is generally with care that's aligned with and responsive to the diverse needs of people who use drugs in their complexity, in ways responsive to different positionalities on the basis of intersecting social identities, due to race, gender, sexuality, ability, etc. Because you can arrange care in ways that are actually responsive to people's needs. And when you do that, you can see the improvement of outcomes. And so here's and I apologize, the text is small because I am not good at developing figures, but here's effectively a model of patient-centered care that we had developed that really considers how we can reshape the context of care for people who use drugs by changing environmental factors to produce conditions that both facilitate better engagement, prioritize the needs of people who use drugs on their terms and in ways that allow people agency, and they'll allow for the deployment of care strategies that are ultimately oriented toward being supportive. That is, instead of being concerned with the enforcement of anti-drug policies, they are concerned with, first and foremost, how they can foreground the needs of people who use drugs and support them. And so this can include a variety of things. It can involve the integration of harm reduction interventions into hospital settings, first and foremost, as a critical mechanism for supporting excuse me, people in care. It can include training to promote cultural competency or safety in care, though also ensuring that staffing is done in ways that is responsive to people's needs and ideally involves bringing people who use drugs on teams as members of care teams in ways that aren't just the kind of recovery coaches that get commonly brought up, especially in US contexts, but that provides space for people who, may or may not be actively using and who aren't explicitly oriented toward recovery, as that may not be a goal of patients, and quite frankly, often isn't. That patient care models recognize that the structural conditions in these settings produce bad outcomes and that they need to be addressed. And so then that can include things like low threshold access to harm reduction supplies, the integration of supervised consumption services into care settings broadly, where possible. Not to set up something separate, but often people articulate the need for spaces with competency, experience, and supports for people who use drugs that are very directed around their needs, and avoid also the discrimination that people may experience from other patients who may be hospitalized. The different supports be available, including an array of treatment options, should a person choose to inject in those. But the pain is addressed in meaningful and direct ways to support people in being in care. Finally, that this effectively remaking of a care setting can work to prioritize hospital care access and risk reduction over other aims, like the enforcement of anti-drug policies or restrictions on prescribing. It can enhance cultural safety and patient-provider relationships by framing out care in a way that can allow for more open communication among people about needs, that is oriented toward care and support. The care strategies themselves can be informed by the direct needs of folks and include responsiveness to pain and withdrawal. And finally, that as a result of all this, that there can be greater shared decision-making in care. And over the last handful of years, we've seen some of these strategies start to be picked up. And what we've consistently seen is that as harm reduction approaches are implemented in care settings, that they're critical in supporting people in being engaged with care. And so one of the key mechanisms through which that happens is by reshaping care relationships and addressing, at least to some extent, though it's very complex, given the longstanding histories of institutional engagements that people may have, the mistrust that people often have in people providing them with care. And that can be critical in addressing barriers to access and facilitating engagement with care. That people can address their needs without having to leave, without having to hide in hospital to, for example, use to address experiences of withdrawal or unmanaged pain. That experiences of pain and withdrawal can be foregrounded and addressed in ways that allow for people to be primarily oriented toward addressing their whatever it is that has brought them into a situation where they need care. And so some early work that we had done, there's an HIV/AIDS care organization in Vancouver that operates a residential kind of a long-standing respite and residential care program for folks who use drugs living with HIV, though it's expanding a bit. And it effectively is adjacent to a large urban hospital. It's nurse-supported care with an attached physician. And one of the critical things about this is it operates entirely under a harm reduction approach, which includes doing supervised consumption, recognizes and allows on-site drug use, and is primarily concerned with supporting people in their care. And one of the key points here that people would often bring up is how critical that is in creating relationships with providers that allow people to stay engaged. And one of our participants put it like this, and I always come back to this as something in thinking through these dynamics. At least they know why I use drugs. They know how my lifestyle was before, and it's the understanding part that I like. They say they're not here to judge us by what we do, but by how they take care of us. And we see that reorientation and shift in the dynamics of care to center folks who use drugs and work to be responsive. And so in work that we've part of a larger group of folks who've since done other work around hospital care, and I'd really like to emphasize there's a fantastic group in Edmonton, Canada, doing this work led by Elaine Hishka and Jeanette. Last name I always butcher, so I'm not going to do it. Where they have implemented a hospital-based supervised consumption service, which is being evaluated, and the early work has been incredibly promising. And what it's effectively showing is a decrease in people leaving hospital because of the many forces that I've described. And that's critical in keeping people engaged in care, which is what we primarily should be concerned with. And so in wrapping up, and happy to take questions, one of the key things that we need to think about as we work toward providing care that's responsive, that's meaningful, that's aligned with the needs of people who use drugs, is to focus on these structures, to focus on these social dynamics or cultural norms within care settings that are driving poor outcomes. To recognize that drug abstinence can't be a goal when someone shows up in hospital, because that may not be why they're there, or when they show up in another care setting. That we need aligned care with what people's needs are, and that involves breaking down these structures, revisiting policies and approaches to create conditions that allow people to stay. And now that's hard. Now that's especially hard within a context of broader prohibitionist frameworks, widespread discrimination against people who use drugs that work to do this. But that essentially is a key point of advocacy that I think we need to come back to, and perhaps other forms of direct action that hold hospitals accountable for their poor treatment of people who use drugs, so that we can build systems of care that are oriented and structured around people's needs, and that work to do what we should all be doing at any moment, which is keeping people alive and supporting their well-being. And so now I'm happy to take any questions, and thank you all for joining and for listening to me go on. Okay, so I see a question about access to medications for opioid use disorder, evidence-based care for treatment through hospital settings. Yes, this is something that's commonly available, especially the proliferation of addiction medicine consult teams has, I think, been critical in improving access overall in hospital. And that's important and that's critical. But one thing we also need to recognize as part of working to support people who use drugs in care settings is effectively that not everybody who's showing up for care wants to be engaged with treatment. And that there are key points of agency and autonomy that we need recognized as part of this. Otherwise, we risk veering into what I have mentioned as things that are experienced as coercive in pointing people to treatment when it's not something that they want, And that only works to undermine things in the long run. And I mean, especially within the broader context of what's happening with the drug supply, this is why I think everybody who in any way cares about or is providing care to people who use drugs need be advocating for safer supply as something that's critical in keeping people alive, especially within the context of recognizing that people may not want to be engaged with a broader treatment or care system. And that the only alternative then that exists is a toxic drug supply characterized by potent fentanyl, swings in fentanyl potency, and all of the other adulterants that are showing up in the supply right now that create incredible risk, but don't need to. And that we have a responsibility to continue to try to find ways to intervene around to support people.
Ryan, thank you so much for your talk. That was incredible. And thank you so much for being part of this as well. We really appreciate it. Does anyone else have any questions? Please put them in the chat. Ryan, did you see the second question as well about the California Bridge program?
Yeah, I did, which I'm frankly not super familiar with. So
yeah, I can chime in a little bit from what I know about it. Basically, it's connecting folks, and actually perhaps Steve, you could include a little bit more, but it's a hospital-based service that connects folks with like outside of hospital buprenorphine, if they're interested in that. And so it improves substance use disorder in hospitals. I don't know, it's kind of going off your talk. I don't think it's coercive treatment, but maybe Steve, you could include like a little bit more about that, or anyone else that knows more about California Bridge. And in the meantime, too, Jeanette has a question as well, which is how important is it for those who experience structural violence to be aware of how it affects their day-to-day life? What are some ways we can empower those who experience structural violence? How would this influence care? For example, calling out coercion when it occurs.
So I think one of the principal ways that we can do that is by supporting drug user organizing. One of the things that we've consistently seen is so much of that work's being done by, activist communities, by groups of people who use drugs that bring an incredibly rich, richer than I could ever hope to achieve, structural analysis to what shapes the day-to-day lives of people who use drugs. And, one of the things that I think we think about is finding ways to empower folks, both in the work that we're doing, but by supporting that organizing, because it can become a critical point of advocacy to remake these systems. And one of the things that we've consistently seen across basically every jurisdiction where we have harm reduction is, it's not something that comes down from on top because, we want to improve care. It consistently happens because people who use drugs and allies demand it and work both within these systems and outside of them to pressure folks to find different strategies that work to effectively build systems that are more humane for folks who use drugs. And I think where we can find ways to activate that, to support it, we have to, because it's actually a critical point of advocacy and of change that really has been consistent across every setting where we've ever seen this happen.
The next question is from Ariel, which just says, thank you for sharing your work and insights. Are there examples of hospitals implementing some of the strategies that your team has proposed? And what have the results been? Example, creating space for safer drug use in the inpatient settings, et cetera.
Yeah, so we've seen these implemented across a handful of settings in Canada so far, though it's really uneven in its implementation. So this looked a few different ways. So there's a hospital in Vancouver, for example, that not directly within inpatient setting, but attached to the hospital, built a supervised consumption site or lower threshold overdose prevention site that served both the hospital, but also the surrounding community a bit. I mentioned a group in Edmonton, Canada, that's doing fantastic work where they're evaluating a hospital-based, it's implemented in part of care, supervised consumption site. that effectively works to do this. And, I think one of the exciting things about this work is it's just showing really fantastic outcomes. And one of the principal ones that we're seeing is that folks are better able to stay in complete care. And one of the things that we know consistently across now decades of research is folks who use drugs, and especially those who are rendered most structurally vulnerable on the basis of racism, gender discrimination, and severe extreme poverty, are effectively the groups of folks who leave hospital before completing treatment more than any other group. And so there's a direct, public health, but I mean, honestly, just human directive to create systems that keep people safer. And so I think the very promising work that's being done showing the efficacy of these should be an inspiration to everybody looking to find ways to improve care. Now, the flip side, which I do feel I need to mention of this, is that remaking relationships and creating situations where people can use safely and be engaged with care, that's an ongoing process. And one of the things that sometimes comes up is, if people are engaged with a site over time, even if it is operating under a harm reduction approach, they may not want to still be seen as someone who's using for the fear of disappointing, to put it in those terms, a care professional that they're engaged with. And I think that really just pushes us to continue to find ways to engage, to meaningfully support, and to make clear that, and again, to go back to that quote, folks who are providing care, they shouldn't be judging the folks that they're providing that care to in any way, that ultimately they're the people who should be being judged on the basis of the care that they provide. And I think that's just a wonderful frame for how we think about providing meaningful support and adopting and integrating harm reduction approaches. That is, the onus is on these systems, on the people within them, to find ways to make it work.
Ryan, thank you so much. We really, really appreciate it. It means so much. It's such important work as well. So really appreciate you being here to share. And at that, it's time